Okay. All right, we're going to get started. Thank you all for joining our didactic. The title is Care in Cuffs, Navigating the Care of Patients in Police Custody. We're just going to do some brief introductions, and then we'll kind of give you an overview for our time together. So my name is Utsa Khatri. I'm an assistant professor at Mount Sinai. I'm part of the research faculty there, where I study the intersection between criminal legal system involvement and healthcare.
Aaron Dorolaski. I'm primarily in the University of Michigan Community Program, Community Hospitals, and Medical College of Wisconsin part-time.
Hey, I'm Joan, third year at Mount Sinai.
Caitlin Farrell, one of the assistant professors at BU.
Hi, I'm Will Weber. I'm an assistant professor at Rush, and I also help direct the Medical Justice Alliance. It's a nonprofit that focuses on rights for patients who are incarcerated.
All right, awesome. So we don't have any disclosures to make. I do want to just give you a brief rundown of our time together. So we're going to go over some slides. That's the didactic portion. And then we're actually going to go over a couple of cases in small groups that we'll all facilitate. So at that portion, we might ask the people in the back if you guys are still able to continue with us to join a table. All right.
Perfect. So I just wanted to start giving us a very brief overview of incarceration in the United States and why this is a very important thing that affects all of our patients. So across the United States, as many of you probably know, the U.S. Has much higher rates of incarceration than most other countries in the world. So there are just under 2 million people who are incarcerated. And that can be whether it's in prisons, jails, detention facilities. Now, anyone who is in the U.S. who is incarcerated has a constitutional right to appropriate medical care. And that's based on the 8th Amendment. It's a right against cruel and unusual punishment. And what the Supreme Court has held is if you are not provided appropriate medical care, then that's cruel and unusual punishment because you have no other way to get medical care. Now, unfortunately, even though people have a constitutional right, many people who are in custody or incarcerated are not getting appropriate medical care. And that's for a variety of reasons. There are for-profit prisons that where there's a perverse incentive to provide the medical care because it costs the prisons a lot more money and it takes out of their bottom line. There are many patients who, even though they are requesting medical care, there can be super long delays, even just getting basic medical care for your high blood pressure, diabetes, things like that. And so what we see is, on average, the life expectancy of someone who is in prison drops about 2 years per year incarcerated. And so we know many other social determinants of health, or things like smoking. We know smoking has a very strong impact on your life expectancy, on your quality of life. And incarceration has a much stronger impact than even smoking. So it's something that is a very a strong social determinant of health for our patients, and something we should be aware of. Next slide. So that brings us to, today we're going to be talking about patients who are in police custody. And now that can be a bunch of different categories. I just wanted to give a very brief overview of kind of 3 typical camps that we'll see in the US, in our ERs. So first are patients who are detained. These are patients who are not yet under arrest, but there are officers believe that there's some indication that they may have committed a crime, so they're holding them while waiting to get a little bit more information and see whether they're going to take them and put them in a jail. Next, there are patients who are actually in custody. These are patients, again, where they're alleged to have committed a crime and they're currently under arrest. They, again, don't have freedom of movement at that point, but they have not been convicted of a crime. And then finally, there are patients who have gone through the legal system, who have been convicted of a crime, and then they usually are coming from a carceral facility such as a prison. So those are the kind of the 3 groups. In general, all these groups, what they have in common is they have limited freedom of movement, and they are going to be having officers kind of attending to them while in the ER. And that changes the dynamic, right? We're used to working with a patient, working with the patient directly, or sometimes with family or other people the patient wants in the room. And once you introduce an officer, that's many times someone the patient does not want in the room. And that has a lot of their ethical dilemmas that go along with that.
So we just want to give two frameworks that are important and are, the principles of the subsequent lessons we're going to talk about today. None of us are lawyers, and so we're not going to, really give you any significant information on the constitutional protections. But we put the slide up there to say that these are rights that are guaranteed by the U.S. Constitution that all of our patients have, including patients in police custody. And so we're not just talking about something that's morally right, what the ethical thing to do is, but these are rights guaranteed to your patients by the Constitution. And so we talked a little bit about the 8th and 14th Amendment already, which you can think of as the right to receive care. But the right to privacy comes up a lot, and we'll go through that in the cases. The 4th Amendment protects all Americans from unlawful searches. And then the 5th Amendment also the right against self-incrimination comes in when we're talking about information gathering in the emergency department. So that was kind of the legal background or framework, but there's also an ethical framework. And this has been described really well by Baker and co-authors in an Annals paper that's now over a decade old. But I would encourage you to read that if you're interested. But another ethical concept that comes up a lot is this concept of dual loyalty. And it's the idea that as a physician, you have a loyalty to your patient, that's your primary loyalty, but then there are many situations where there'll be a third party that you also have a loyalty or an obligation to. So that might be insurance company, for example, or it might be your health system, for example, when there is something that you are obligated to perform for a third party that may conflict with your loyalty to your patients. And then another, ethical concept that we have to talk about when we're talking about this topic in these patients is of equity. There's overt racism in every aspect of the criminal legal system, whether it's surveillance of patients, of people in their communities, to booking and stopping and frisking, to arrests, to sentencing, across the entire spectrum. People who come into contact with the criminal legal system are disproportionately Black and brown. They're disproportionately poor. They're disproportionately suffering from mental illness or substance use disorder. And so when we talk about this issue and protecting the rights of our patients that they are guaranteed, it's not just an issue of ethics, but it's really an issue of racial justice.
All right. I'm going to talk a little bit about how this translates to a clinical space. So first off, we're all assessors of capacity. And as you know, I won't belabor the point, but there are these 4 components of assessing capacity. There's understanding, the patient has to understand the facts. They have to appreciate the consequences, and they have to display a logical reasoning and communicate this choice to you. So, when you deem that a patient does have capacity, assessing this in a patient in custody is no different than other patient groups we do this for. So your demented patient, a psychiatric patient. And therefore, they do have the access to this constitutional right to refuse if you deem that they have capacity. So under this right to refuse, this includes they can refuse speaking with providers or the police. They can refuse the search of their belongings or their person, and they can refuse any medical workup or intervention that you are offering them. So therefore, the violation of this right to refuse could be considered a constitutional violation of their rights. A couple other things about this. Officers should not be considered surrogate decision makers if there needs to be a clinical decision to be made. And when in doubt, there's always individual hospital policies and a risk management group in your hospital that you can refer to.
All right, so just like with any other patient, protecting patient privacy is critically important, not only to providing excellent medical care, but also to fostering the physician-patient relationship. And patient privacy, as we have discussed, is not only grounded in medical ethics, but in federal law as well, namely HIPAA, which we all know and love. So this, of course, applies to patients who are in custody as well. But a lot of times, protecting privacy of patients who are in custody is very challenging because of the presence of third party, namely the officers who are there within the room. I will often get asked by my learners, am I allowed to ask an officer to step outside of the room in order to interview my patient? And my answer is always yes. Not only can you ask, but you should be asking. This is best practice. So while officers need to maintain a line of sight of the patient, most commonly, they do not have to be within earshot. So it is perfectly right and legal in 99% of instances to ask officers to step out of the room. So some other best practices are when you are interviewing the patient, being mindful of the discussion that you're having and avoiding any incriminating topics or discussions, really saying, is this information relevant to their presentation in the emergency department today? And also asking the officers to turn off their body cams. Now, this has a little bit of a caveat because each state has their own laws about body cams. But if you think about it, many officers will have body cams that are recording all of the time. So that is not only a violation of the privacy of your patient, but any other patient that they might record as well. Now, we know that it can often feel scary and overwhelming and intimidating to ask officers to step out of the room. So we wanted to just take a little breather for 30 seconds and have you guys turn to one another and just ask the officer to step out of the room. I find that having a little spiel when you do this makes it easier in real life. So 30 seconds, just go ahead and turn to your friendly neighbor.
I want to take a picture.
You can ask someone to share if they have a phrasing, and then maybe you can provide yours.
You want them to share?
Yeah, if anyone. Or you can share what you say.
It can be your officer.
All right, amazing. That was slightly more than 30 seconds. All right. Awesome. So you are now fully empowered to do this during your next encounter with officers. Amazing. All right. So continuing on the theme of patient privacy is the legal framework of the third-party doctrine. Of course, again, all of this with our asterisks. None of us are lawyers. Most of us up here are maybe wannabe lawyers, but not actual lawyers. So as we mentioned earlier, all patients, all people within the United States are protected under the Fourth Amendment against an unreasonable search and seizure. So when Jay-Z says, I know my rights, so you're going to need a warrant for that, that's what he's talking about. It's your Fourth Amendment right, okay? But the third-party doctrine, which is this legal framework, allows a way to sidestep this constitutionally protected right. What is the third-party doctrine? So the third-party doctrine, it allows officers to use any information obtained, anything that's overheard, any physical property that is obtained from a third party that is no longer subject to this Fourth Amendment right. It can be used in legal proceedings in the future. So I think the most common way that this is demonstrated in our emergency departments is in the trauma room. So for example, if officers follow a patient into a trauma room and they are there observing, anything we call out in our primary, secondary survey, anything that is overheard, can then later be used in legal proceedings. Anything that is within plain view is also able to be seized by law enforcement. So as we're taking items of clothing off of the patient, as we are taking their personal property, as long as it's within plain view of the officers, they are allowed to take it via this legal doctrine.
Another really big thing that you guys will bump into when you're trying to discharge someone who is in law enforcement custody, or there are a few different topics where it's different. First off, our patients are typically able to access their medical records after being seen by us. First off, we give them a discharge summary that has kind of a concise view of here's what happened, here are your next steps, here's your follow-up, things like that. Now, and in addition, they typically would be able to log into their MyChart or other online medical record options where they can see what happened in the ER. Now, for patients who are in custody, especially for those who are in a carceral facility, they are not allowed to have any of those documents after leaving the ER. So it's considered contraband. Whatever discharge instructions you give to them are going to be taken by the officers, and they're not going to have any access to that. Now, if they are in prison, if they're in jail, they can still request those medical records, but you're looking at months until they're going to actually get those medical records. So the first thing, as you're going to be discharging patients, take that extra time, take the extra 3 minutes to really explain it well, because they're not going to have any written documentation. So they need to know exactly what they need to do, what meds to take, what happened to them. So that's the first one. The second one is medication access, and just considering what's happening as you're dispositioning them to the jail, the prison. So our average patient, you tell them, okay, you can go to Walgreens, you can go to CVS, pick up your prescription, or go pick up some Tylenol, some ibuprofen to take for your broken bone, things like that. Now, patients who are in a carceral facility have a lot of impediments, even just to getting over-the-counter medications. So one, they many times they can't get those over-the-counter medications. Many carceral facilities will have something called a commissary, where you can sometimes buy limited medications, but they may not have them in stock. And many times the patients who are actually incarcerated or in a facility, it's because they didn't have good access to money, right? Disproportionately, people of lower socioeconomic status are put in prison. And if you're going to be working in prison, many times patients will be making, between 5 to 20 cents an hour. So if you're telling them, oh, just take Tylenol or ibuprofen, and it would be the equivalent of 15 hours they have to work just to get a bottle of ibuprofen, it just may not be feasible for them. So one way you can help ensure a continuity of care is actually just prescribing basic over-the-counter medications. So taking those extra 30 seconds to put in a prescription for Tylenol and saying, take this, 650 milligrams acetaminophen TID for your pain, will help allow the people at the carceral facility to continue that medication instead of forcing them to try to get it through commissary. Also, as you're sending these patients back to a facility, many times just be real aware that these facilities don't generally have a physician at the facility at 24/7. They might have a nurse overnight, but many times if they have their seizure medications, if they need anticoagulation, things like that, it's really not going to be feasible until at least the next day, or even till the weekend is over. So being considerate of that, and if you can, try to get them their dose of their seizure medication, try to get them their DOAC or whatever they need. And similarly, if you're going to be sending them back at 6, 7 o'clock at night, just realize the kitchen's going to be closed. There's no mess hall, and so they're going to not be able to eat until the next morning. So a quick turkey sandwich for the road is very appreciated. And as long as you're clearing food with the officers beforehand, you can give them whatever food you want. Now, being aware that silverware generally should be plastic, and clear it with the officer. Or if you have a psychiatric or a safety tray, that's usually preferred. Finally, follow-up planning. Last one. For our average patients, we typically will tell them, follow up with orthopedics in 2 weeks and things like that. Now, it's a lot more difficult to plan that for patients who are being discharged to a carceral facility. So things that you can do to help ensure that is, one, being very specific. So once they get the discharge instructions at the carceral facility, giving a very specific framework of what time should they see the the specialist and what type of specialist, just so that they can kind of ensure that that happens. Or if it's not happening, then the person can reach out and say, Dr. So-and-so recommended I need to see a GI doctor within 2 weeks. It's not happening. So that gives a lot more impetus for the facility to actually make it happen. So there's some of the discharge considerations. Next is communication. This is another big topic that's different from our typical patient to a patient who's in custody. So first off, discussing with family. So typically, if our patient wants us to communicate with the family, completely fine. We make these phone calls all the time. It helps with their discharge planning to figure out, do they have support at home, things like that. Now, for patients who are in police custody, it's still okay to reach out to family in the vast majority of cases. Now, from the legal standpoint and the law enforcement standpoint, what they are concerned about is safety. And so this is where it changes a little bit. The concern would be, and this is extremely rare, but the concern would be that if you tell the family or tell the close friend, this patient is in so-and-so ER, in bed, whatever, and he's here, then they might try to come, break them out, or otherwise create some sort of unsafe environment for the ER staff or the security officers. So generally, if you're going to contact family, it's still okay. They can be the surrogate decision makers and things like that, but it should go through the law enforcement officers. So telling them specifically, here's the family I want to contact, some general things, I just want to give them an update on the patient's status, and then trying to avoid any really closely identifying information of what specific area they're at. And many times they will want at least a monitored line. Again, this can be difficult. You're trying to maintain the patient's HIPAA and then privacy, but trying to make sure that you're at least working with law enforcement to keep safety. The other thing is handoffs to the facility. With the facility, many times all they get is the medical records, the discharge instructions that you provide to them. So if you have the ED note done, it will be really helpful to the facility to see what actually was done in the ER, because they won't have access to the electronic medical records. And for them too, they have to go through through the medical records department, and it can take days to get information. So best practices for this is, if you can, discharge instructions and the ED note. The officers who are in charge of the patient, again, they're not clinical people, they're not medical people, so they do not have a right to know what's going on with the patient unless it specifically impacts their transport. So if the patient is high risk of seizures, you can tell them, if they have a seizure, this is what to expect, and bring them back. But otherwise, you shouldn't really be going through details. So ideally, if you can, take those medical records, the discharge instructions, put them in a sealed envelope for the facility. Or even better, give 2 copies and specify for the facility, one of these should be for the patient, one should be for you. Because if the facility gives them those medical records directly, then it's not considered contraband. Any questions about that? I went through a lot of information. Okay, we'll continue on.
All right, so now we're going to do some cases. So if people in the back could join some tables. I know there's not room at all of the tables, so we'll make a group back there as well. So not all of you have to move. But we're going to, there are 2 cases. We're going to present it on a slide. We have some questions just to talk about your experience, what you have been doing, what you would do maybe after some of what you've heard, and then we're going to all report back as a group. So 5 minutes of discussion with your group, and then 5 minutes as a whole group. So this is the first case. It's an 18-year-old patient who has a gunshot wound to the thigh. It's a superficial through-and-through injury. The patient is stable with stable vital signs. And importantly, the patient is not in police custody. But the police are present in the emergency department, and they insist on being in the room during your trauma evaluation, and then attempt to confiscate the patient's phone.
We'll try to break into 5 groups, and then we'll come and join you all.
Yeah. If folks want to come to the front 5 tables, I think we have about 30, 35 people, so that should work. Okay, we're going to go on to the second case. Thank you for all the lively discussion. I'm just going to briefly go over some teaching points from the first case. So as we kind of talked about in the beginning, and I'm sure you guys addressed this in your groups, none of us are constitutional scholars, but patients are protected from unlawful searches by the Fourth Amendment. If patients aren't detained, yeah, so thanks. If they're not, if patients aren't under arrest or detained, you can ask the law enforcement officers to leave the room, and you can ask them to leave the ED if the patient's not in custody. And if they are, as we discussed, you can certainly ask them to be within the line of sight but out of earshot. Now, they might not agree to do that for safety reasons, and then you have to negotiate that. That's kind of one of the conflicts that arises and why we have these discussions. So at least you're better informed, but it doesn't mean that you'll have the answer ready at your fingertips and that nothing will go awry. And we'll talk about that more in the next case. And that there's really no obligation for you to provide protected health information or belongings to law enforcement officers if they don't have a warrant, although I know in practice we often gather them, especially when we're in the trauma bay with these GSWs, everything's gathered and bagged. And if there is a warrant, you can defer to someone else. You don't necessarily have to execute the request for information gathering yourself. You can defer to medical records, you can defer to your lawyers or even your supervisor. So I just want to empower you with that information, even though I know in real time when we're having these discussions, it could be a little fraught and stressful. So I'm going to move on to the second case. And just so you know, there is an ASAP policy, and we've linked that in our bibliography that kind of describes some of our professional society's expectations of these responsibilities. And we also wanted to highlight that, mandatory reporting laws, including things like patients who are injured by GSWs and stab wounds, there's a lot of variability between states. So be cognizant of that. One thing I really want you guys to take home is that there's the constitutional law, which I think most of us are not scholars of, but then there's specific state laws, and then there's local ordinances and institutional policies. So there are multiple layers that really often create complexities, and I don't think it's reasonable for all of us as physicians, especially during the kind of stressful moments when we're caring for patients, to understand all of these, and there's many dynamics. But do be cognizant that the more you kind of learn about these, the more you're empowered, I think, to provide the best care for your patients. Again, these are never easy. The second case, and this is also one that I was involved in clinically, was a 32-year-old gentleman who was in police custody. I received him actually after sign out, and they were someone who was presumed to be selling cocaine, got pulled over and then stuffed a baggie of cocaine and swallowed it while they were, being arrested. And when I saw them, they were in leather restraints in the trauma bay. They were hypertensive, 220/110, but they would not talk to me. They were awake and making some eye contact, but they would not have any discussion with me. And when I talked to the officers at the bedside, they told me they were waiting for the warrant. So this patient was refusing care. They wouldn't let me examine them or order any tests, because obviously I was worried a hypertensive patient with cocaine ingestion might have a toxidrome, right? So I get the warrant, and the warrant says you can proceed. You should proceed. We insist you proceed with oral cavity searches, rectal cavity searches, that you put an NG tube down and obtain a gastric fluid sample, that if that's non-diagnostic, then we'll proceed with upper and lower endoscopy, and if those are non-diagnostic, we will proceed with laparotomy to find the baggie of cocaine. So this was presented, this is a signed warrant from a judge.
Where was this?
This was in Saginaw, Michigan, at St. Mary's. Yeah. So let's gather around again our tables, and we'll talk about this case in a second.
I will be ignoring that warrant. I will be assessing it based on who's having it delivery. And then if you're assessing I need to find against the suspect or not against the suspect. But it's not going to talk to me in self-capacity. And then he's going to have to stay. But I will explain it out to you. You have to leave, officer. Sorry, you get all the credit. But I'm not Yeah, I was gonna say like our case. Yeah. The guy choosing her up right there. Yeah, he should get a splash on across his face. Yeah. And then we were like, let us get him out, and he. And so is the trauma attending the side, and so like the whole thing was like, like is he stable? He's kind of he's like aroused from this horrible situation. We need to make sure that yeah, we talk yeah. Yeah.
I think if he has capacity,
And the whole thing about how like that people were just like asking and like we weren't telling them, and then like exactly what was going on.
What happens when we do like when we give them to charge and they break it around? I was just thinking of like the plain view thing. Like, you know, if we did take it out to their academy, they had to take it out, but then it has to get from the trauma bay to wherever that locker room is. There's so many processes. It's so easy to let me tell you.
So I had a case.
Yeah.
I had a case. Aaron, do you want me to present it or where a patient admitted? I was the first person to admit a patient that has
We're done at 4:50. What's that? We're around 4:50. Yeah. Okay. So thank you again for all of the lively discussion. I think in the interest of time, since we have a minute and a half left, we'll just kind of wrap things up. And if people want to stay and chat more, we're happy to chat with you. But again, just to reiterate, like patients in custody with decision-making capacity, which was the case in this, with this case, do have the right to refuse treatment. And that, we want to just highlight that the responsibilities and objectives of us as physicians and law enforcement are maybe conflicting, and that can complicate patient care, but it's our responsibility as kind of the captains of the ship to navigate these tensions and conflicts. And I also want, and the ACEP has endorsed, that if you are someone who, when you've identified that a patient doesn't have a medically indicated reason to do what a law enforcement officer or judge is asking you to do, may conscientiously object, but that doesn't mean that there aren't potentially legal ramifications for you as the provider should you do so, meaning should you refuse a signed order from a judge to perform a forensic examination.
One quick point I'll add. Our table talked about this a little. If there is a warrant or something and you don't feel like this is medically indicated or something, what you can do is defer to staff safety. If you are concerned, like this patient there's concern about intoxication, they want you to do a lab draw. If you are concerned that this patient might lash out, injure a nurse or something, document that in the chart because that will support you. If anyone comes and questions your judgment, like why didn't you fill this warrant, you can just defer, I'm trying to keep my staff safe. And it's very, very rare that they would try to go after you because it's such a reasonable thing and it wouldn't look good.
So, and just in terms of take-home points, again, we talked about balancing our ethical duties to patients with kind of knowledge and deference of state, local, and federal rules and institutional policies. Patients, again, have constitutionally protected rights against unlawful searches and involuntary treatment. And then when you're not sure exactly what to do, go back to what we were taught as students and thereafter, which is, provide the patients the same standard of care as you would anyone else. And when you run into issues, ask a friend for help, whether that's your medical director, whether that's looking up institutional policies, whether that's calling risk management or your hospital's legal team. There's almost always someone you can go to 24 hours a day to ask for help. Thanks, everyone.
Thank you guys for coming.